Welcome, everyone, to Let's Talk Patient Blood Management podcast. My name is Sarah Wolbolt. I'm here with Marianne Sromoski, and we are very excited to start our second year of podcasting.
Absolutely. I'm really excited about today and so excited to be starting into our second year. Yes, very exciting. So today we have the honor of having Dr. Neil Blumberg here with us. And Dr. Blumberg is the Director of Transfusion Medicine Division and Blood Bank of the 880-bed hospital at University of Rochester. He started there in 1980. He earned his BS and MD from Yale University in New Haven, Connecticut. And he also completed his residency in laboratory medicine, hematology, and blood banking at Yale New Haven Hospital. He has a particular interest in transfusion immunology, having participated in research into the previously unappreciated immunologic effects known as transfusion immunomodulation. Dr. Blumberg's clinical interests are in the diagnosis and treatment of immune disorders such as autoimmune hemolytic anemia, autoimmune thrombocytopenia, supportive care for stem cell and solid organ transplantation, and use of minimally costly and simple techniques for mitigating transfusion side effects through Lucar Reduction, use of autologous transfusions, and removal of stored supernatant through washing. The Rochester group, co-led by Dr. Joanna M. Heel, MRCP, has defined the benefits of ABO identical transfusions through novel and clinical laboratory research and described the unfortunate ill effects of transfusing ABO-incompatible soluble antigens and antibodies. The combined use of Lucar Reduction, washing, and ABO-identical transfusions has reduced the mortality of younger patients with leukemia from 50 to 20% at 5 years post-diagnosis. Wow. So this group has also demonstrated a reduced incidence of platelet refractoriness to close to zero through the use of Lucar Reduction and avoidance of infusing ABO-incompatible antigens and antibodies. These strategies also reduce side effects such as inflammation, organ failure, transfusion reactions of all types, including trolley, taco, and alloimmunization to red cell antigens. Reducing unnecessary transfusions also mitigates these unfortunate and undesirable consequences of transfusion, including thrombosis. Did I cover it all, Dr. Blumberg?
Yes, absolutely.
Awesome. That's pretty cool work you're doing there. That's very exciting.
Welcome, Dr. Blumberg. You know, Mary Ann and I, neither one of us are transfusion experts. We are experts in patient blood management. However, we work every day side by side with clinicians, nurses that are transfusing blood every day. And so we hear a lot of popularly held beliefs or thoughts about transfusion. We'd like to run some of those by you and have you as the expert weigh in on, is it fact or fiction? Teach us a little bit more about the truths and the myths behind transfusing. Does that sound good for you?
It sounds excellent. Thank you. Thank you.
Okay.
And thank you for the privilege of addressing you and the listeners of the podcast.
So I see in notes, doctors' notes pretty often, like transfuse once we hit that trigger of 7. Right. So how do you feel about that? Is that what we should do? Just go by 7? Is that based on something?
Well, it represents a misunderstanding of the more recent literature. There has been, as I said, a historic bias in favor of using transfusion, and it was based on numbers. If you came into the hospital when I was a resident or a young physician, and your hemoglobin was below 10 and your hematocrit was below 30, well, by God, you could be sitting there conversing animatedly with your family, and by God, you were going to get 2 units of red cells.
Right.
And during the 1990s and 1980s, it became clear that transfusion was causing more problems in many patients than it was helping. And so clinicians investigated, could we use another number? Did we need to use 10 and 30? And the answer came through loud and clear over the starting in about the late 1990s through the next 10 or 15 years through multiple high quality clinical studies called randomized clinical trials, that if you use the number of 7 and 21, hemoglobin 7, hematocrit 21, which is substantially different, obviously, from 10 and 30 in many ways, both clinically and numerically, that you might actually do better.
Yeah.
And certainly you didn't do any worse. Although there's still some clinicians who have their doubts about this. It's hard to change people's religious beliefs
Yeah.
and long-standing habits, But instead of realizing that what this said is we could be more conservative, it didn't answer the question is should we be using numbers as the primary indication? And the
Right.
answer in and I don't make transfusion decisions because I'm not practicing at the bedside, but my experienced colleagues in hematology, intensive care medicine, anesthesiology, surgery, etc., say no, don't use the number. The number helps tell you what the trajectory of the anemia or platelet count or whatever is, but it doesn't in itself constitute, with rare exception, an indication for transfusion. The exception would be in platelet counts of less than 10,000, but that's not what most of the time we're making transfusions decisions based on.
Right.
So we don't know, to be honest, and there's reason to suspect that there isn't a number that we can use beyond which everybody does better than they would without transfusion. In other words, let's say the number is 3,
Mm-hmm.
hemoglobin of 3 instead of 7, dramatically different. It may not be that routinely transfusing everybody at 3 yields better results for most of the patients. It may be, and we don't know for sure, but we suspect it may be the case, that making a clinical decision integrating all the information, as you would say, about blood health, if you want to call it. But what I would say as a hematologist, it's based on what's the cause of the anemia? What's the likely trajectory in the future of the disease causing the anemia? What are the patient's current signs and symptoms of anemia? What other options are available clinically that may be more effective and or less toxic?
Thank you. I'm going to move on to my next question. Red blood cells carry oxygen. That's how our vital organs get oxygenated. So if I'm low on oxygen or not perfusing well on oxygen, a red blood cell transfusion will increase my oxygen capacity to my vital organs.
Yeah, and indeed, that is, if you read textbooks and review articles by hematologists and transfusion medicine doctors and critical care doctors, pulmonologists, etc., that is the main reason we transfuse red cells. The question, as you say, is this true? And the
Mm-hmm.
answer is, well, we don't know for sure. And we don't know in what clinical situations. What we do know is that during storage, red cells are no longer normal. And when we transfuse them, they don't behave like normal red cells. They don't release oxygen. And in fact, my colleagues here, including Dr. Majid Rafai and Christine Cahill, have published a very interesting paper, and others have published similar data suggesting that the evidence of oxygen in the blood, actually, whether you measure it as pressure of oxygen or what we call percent saturation of the hemoglobin, which is often used, that actually goes down acutely, which is, of course, not the desired effect. And what we'd really like to know is what about the liver and the heart? What are they experiencing? Are they getting more oxygen when you transfuse somebody? Or are they getting less oxygen or the same amount? Does it make any difference at all? And we don't really have an answer to that. So I think we have to say that we're still uncertain about what the effects are. We know the physiologic effects are negative. Does this have a negative clinical effect acutely? I don't think we know that either. We do know from some studies that it looks like because transfusions are inflammatory and change the viscosity of blood and they promote thrombosis, that in fact you may be more likely to have a heart attack or a stroke, for example, after a transfusion than if you are without the transfusion. That's a fairly controversial thing to say, but that's what the evidence says thus far. So we need to be very cautious about saying, okay, we're going to improve this patient's oxygen delivery. On the other hand, there's no doubt that we have stories of patients who are feeling terrible and they get a transfusion and they feel a lot better.
Yeah.
How much of this is the placebo effect? How much of this is real? Is it due not to do anything to do with oxygen delivery, but with the biophysics of the microcirculation that we don't fully understand? So this is a vast unexplored territory.
I'm glad you brought that up because I was thinking about that. Like I feel some patients will say like, oh, I got a blood transfusion or I'm going to get one and I'm going to feel so much better. It's almost like patients get emotionally attached to having this transfusion and they have this positive thought in their mind. And it's interesting.
Yeah, I think there's no doubt that something's going on there, but it's very hard to sort out the placebo effect
Right.
because it has often been the case in both personal experience and observed experience that the physician and the nurse who's doing all the work, mind you, the nurse at the bedside, whether it's an outpatient or inpatient, says this is going to make you feel better. You've got a disease, and we can't do much about the disease, but we're going to make you feel better. This is, what we would call in medicine palliative therapy. It's making patients more comfortable, et cetera, enabling them to do more of the activities of daily life. And when somebody tells you that, it can have a dramatic effect. And what studies have been done looking at this issue suggested some patients indeed do seem to feel better and have better physical capabilities, and others have worse. And and we don't know why that is. It could just be random noise.
Right. So, in going with the theme here, transfusion is not always clinically indicated, but sometimes is. You have to look at the clinical picture. You don't necessarily need to go or ought to go by the number. And, sometimes you really have to make a judgment. Even though the patient thinks it's going to make them feel better, you really have to look at the whole picture and decide what's best, what's safest for them, really. Yeah.
I think that's fair. And even very experienced clinicians in hematology still are under the impression that if they let their patients get hemoglobin or hematocrit too low, they're going to have a heart attack or stroke. When in fact, the evidence to date is that the opposite is true.
Right.
So, in a patient who's feeling terrible in hospice care, maybe the risk, and you read most hematology and transfusion medicine textbooks, and they're in denial of the last 30 or 40 years of research. They don't mention the transfusion risks of a deep vein thrombosis or stroke or heart attack following transfusion, of inflammation, of acute lung injury, of organ injury.
Yep.
These are much more serious things than feeling a little tired. I don't want to in any way devalue the importance of treating fatigue, depression,
Absolutely.
inability to brush your teeth or get out of bed. These are all obviously critical things, whether you're near the end of life or you're in the nadir of some treatment, you're at the lowest point of some treatment effect. But if the treatment carries such severe risks, we may need to recalibrate how we think about that. And that's particularly true in, patients with hematologic diseases where we've traditionally been very, very liberal in transfusion of red cells.
Very good.
Love that. So, speaking of transfusion, so I'm AB positive. I don't know why I love to brag about that, but say I'm say I'm O negative. Okay, so I'm O negative and I'm what they call a universal donor and my blood is safe to give to anybody, right? Anybody can get Marianne's blood. It's just safe. It's O negative. It's universal donor. Is that true or false?
Well, I know this is going to sound a little bit like being a negative Nelly about these things, but transfusion medicine or blood banking is a fairly old therapy in modern medicine. Dates back over, the better part of 100 years or more. Didn't become common until the 1940s or 50s or later. The state of the art of blood transfusion immunology in most textbooks is it's still echoing state of the art 1960 immunology. And we've made some serious errors in judgment. It is true that in a life-saving emergency, if you don't have the patient's ABO type or there's no time to get the ABO type, or you don't have the patients, if the patient's group AB and you're in a small hospital and you don't have any AB blood, that we've used group O blood, particularly ORH negative, as what we call universal donor. But that was really meant as an emergency maneuver, okay, when you don't have any other choice.
Mm.
And unfortunately, that became transmuted into O negative is just as good as ABO identical. And that's absolutely wrong. It's an emergency maneuver when you don't have any other choice. And so, therefore, O negative donor blood is very valued, particularly in small hospitals that don't maintain an inventory of all the 8 ABO and RH types. But there are some very large university hospitals that will use O negative for non-group O patients when they have in stock other, blood components of the patient's identical to the patient. And so that, in a sense, it's true. We need more O negative blood than O negative patients in the population because there are so many small hospitals that stock nothing else.
Right.
But they are not equivalent in terms of efficacy or safety, particularly safety. We have numerous reports of severe hemolytic reactions. They're not common, they're rare. When you give a group O red cell that has a little bit of plasma in it, that's incompatible with the recipient. It doesn't happen often, but it's clearly not as safe as ABO identical.
So I have seen this in practice. And like you said, often it's times where maybe it would be inconvenient to wait for a cross match. So, say a rural hospital or an outlier hospital, they're treating someone, they decide that they're going to send that person to a larger hospital, and their blood count is low. So they go ahead and they transfuse with non cross matched blood, because if they waited for the cross match, it wouldn't even be usable when they got transferred. They would have to recross match when they got to the larger hospital. So is it just a convenience thing? Like, what would you recommend to hospital organizations that maybe they had that practice?
I would say simply do not use group O negative or O positive blood for non-O patients except in an emergency.
So like a mass transfusion situation?
Well, it could be any number of things. It could be a patient who's severely anemic due to GI bleeding. It could be severely anemic and symptomatic due to, it'd be rare, but nutritional deficiency, whether it be B12, folate, or iron, but where the transfusion is potentially life-saving. To give it now as opposed to waiting an hour or two till they get to a hospital that has ABO identical, or you get an ABO identical unit from your blood center. What I'm suggesting is that we should not become cavalier about doing this. We should not do it for convenience of the transfusion service or the treating nurse and physician. It should be a life-saving transfusion if you're going to cross the ABO barrier.
Right, not because of supply issues or what have you.
Yeah. When there's no other choice, both in terms of time and the need for transfusion.
Is this, we're talking about red blood cells? Is this, and I don't want to get too deep into this with this next question, but is this true for platelets also? Same rules apply?
Well, this is a very controversial area, and our group is infamous or famous for our position on this. But we have data, and everybody else has dogma. There are 2 randomized trials showing that ABO identical platelets are both more effective and safer than the traditional concept, and even major organizations like the American Society of Hematology promote this idea that ABO doesn't count for platelets. It's total nonsense. Total nonsense. And the only thing I can say is that it's been the way blood transfusion services have been functioning since the invention of platelet transfusion almost, 50 or 60 years ago. Some of the experts in the field promoted this idea, even though they had no data. And I think everybody was relieved that when they gave ABO mismatched platelets, nobody dropped dead. Nobody, had the kind of acute transfusion reaction that we sometimes see with red cells. And so, in fact, the major recommendation is to give major incompatible, such as like a group A platelet, to an O recipient. And this is nuts. We now have data this actually makes bleeding worse. So it's clear that not only are the platelets not working to provide hemostasis and clotting, but they're harming the patient. They're making bleeding more likely or making bleeding worse. This is the major tilting at windmills and crusade of my terminal phase of my career. In fact, we just published a letter on the subject with the American Journal of Perinatology about premature newborns and what's probably going on when you give them large, repetitive doses of ABO missed transfusions. It's unfortunately associated not only with bleeding and lack of response to transfusion and platelet number, which is the usual way of assessing this, although the important thing is bleeding, obviously, but it may actually increase mortality. We're literally, with the best of intentions, transfusion services are killing patients with this misplaced dogma. I think, I can't quantify it, but all the credible data tells us this is really a bad idea. And we should have realized that if giving ABO major mismatched red cells was a bad idea, that platelets, while they don't have hemoglobin in them, have all sorts of other things in them, and that getting platelets covered with, IgG and IgM, anti-A or anti-B antibodies, that these cells might circulate. They might be in the circulation, you can count them, but they're probably not functioning as platelets anymore, and they're probably injuring endothelial cells and causing vascular damage, and thus making bleeding and interfering with, the what we call the hemostatic system, the coagulation system that prevents bleeding or mitigates it. And so this is I'm afraid you asked me what time it was, and I told you how to build a watch, but uh, the myth that ABO doesn't matter for platelet transfusion is one of the most damaging myths in transfusion medicine. And unfortunately, it's been promulgated by experts, and when you just have maybe one or two or three groups saying, no, that's wrong, look at these data. It's hard to get blood transfusions for services. When I talk to people, they say, "Oh, we never could do that. We'd have inventory problems." Blah 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 blah. I get that, but that's not a good reason to be harming patients.
Right.
Figure out a way to do it, or at least to mitigate it. Do less bad. Find the patients who are getting repeated transfusions and give them ABO identical. I mean, we developed this literally over a 30-year period. We didn't institute it overnight.
Right.
But let's put it this way. There's one large randomized trial looking at platelet transfusion dose, and they had a bleeding rate of what they call WHO grade 2 bleeding, which is sort of like, serious but not life-threatening bleeding. It's a bloody nose, things of that sort. You may not need to be transfused. They had a bleeding rate of 70%. In our studies, we have a bleeding rate of 5%. So there's a 14-fold difference, and I think this is almost entirely likely to be accounted for by practices related to ABO.
Talking about making transfusions safer, Lucar Reduction is a big topic in the hospitals and healthcare system. And I heard in your bio that you've done a lot of work in this area with Lucar Reduction. Can you explain to the public what that is and how is it making transfusion safer, and is it making transfusion safer?
Well, this is another area where we've been on the losing end of a controversy. We're not the only ones. Lucar reduction is a very simple procedure by which you use a special sort of filter on red cells and a similar sort of filter on platelets. And it removes about 95, 99, 99.9% of the donor's white cells. Also removes the platelets from the red cell concentrate. Why might this be important? Well, it's been known for a long time that red cells do not carry certain transplantation antigens called human leukocyte antigens, and that if you remove those, in the form of the white cells, you can prevent patients from becoming sensitized, making antibodies. Why is this important? Well, when we give you a vaccine to COVID, you make antibodies to COVID, and that's a good thing because you're less likely to die of COVID. But when we're giving you a transfusion, we don't want you to make any antibodies because they can cause disasters clinically or make clinical treatment difficult. So it turns out that leukocyte reduction was primarily developed for two reasons. One, to prevent sort of fever and shaking chills after transfusion, which are very common to non-Lucar reduced blood. Doctors in the blood bank don't worry about that too much because they don't have to talk to the family and they don't have to talk to the nurses and they don't have to draw blood cultures and and do all the fever workup. But the most important thing that they were developed for was to prevent these kind of sensitizations that prevented organ transplantation, prevented future safe transfusion of particularly platelets. So Lucar reduction turned out to be very important in that regard. And if you combine it with ABO identical, we have nobody making antibodies to
Yeah.
anything.
Yeah.
With rare exception, which it's nothing's 100% in medicine, but it's by far the best anybody's ever reported. But it also turns out that it not only stops you from having these acute transfusion reactions with fever and shaking chills, what we call in medicine rigors, which are very uncomfortable for the patient sometimes, but it also seems to minimize more serious complications such as postoperative infection due to immune modulation. It seems to reduce the risk of acute lung injury or cardiopulmonary edema. And that hasn't been well understood and it hasn't been well accepted, but I think the data are very clear. When we introduced universal Lucar reduction, our rate of central line, intravascular infections went down dramatically. Our
Mm-hmm.
rate of acute lung injury went down by close to 90% reports of that. And work done by many other groups have suggested that removing the white cells, you're removing a lot of other things that the body doesn't like being infused into the lungs. Things like DNA,
Mm-hmm.
proteins that are associated with DNA called histones, something called neutrophil extracellular traps, with neutrophils being a type of white cell. So we got lucky on that one. That Lucar reduction turns out to be it's the proverbial free lunch. It
Mm-hmm.
costs like $20 and it prevents hundreds of dollars of length
Right.
of stay and injury. I mean, forget about just reduction in suffering and morbidity and mortality. It's really cost effective because
Yeah.
it saves when you save. I mean, mostly in medicine, if you want to save lives, you got to spend money. In
Right.
this case, you spend money, you not only save lives and reduce suffering, but you save money for the
Yeah.
whole system. Of course, it raises the cost in the blood bank, obviously. So I see Lucar reduction as the third great advance in this field of transfusion medicine. The first one being the ability to give safe non-hemolytic transfusions. The second one, preventing transmission of diseases like hepatitis C and HIV through testing developed by people like Harvey Alter, who just won the Nobel Prize a few years back. But this is the third great advance. Lucar reduction is terribly important. Nobody should get non-Lucar reduced blood. If you're a patient and your hospital doesn't use 100% what we call universal Lucar reduction, by God, make sure you get your Lucar reduced blood because your chances of doing well with that transfusion are greatly increased. And it's not a problem in Canada or the United Kingdom or France, most other countries, because they adopted universal Lucar reduction sometime between 1998 and the year 2000, which is when we implemented it here in Rochester. But there still are American hospitals
Yeah.
and that are giving non-Lucar reduced transfusions. And neither the AABB, the primary professional organization, nor the FDA has provided, I think, meaningful guidelines on this.
I think people get scared off by that little bit of cost, but they have to put into perspective, as you said, it saves tremendously more, even, by spending that extra $20 per unit or whatever it is that it costs. You're saving so much in the long run.
Do not accept a transfusion if it is not Lucar reduced. I mean, there may be places in the world where they literally cannot afford it, but that's not the United States.
Dr. Blumberg, I really want to thank you for joining us today and bringing some clarity to, just knowledge and informed choice for patients who choose to listen to our podcast. What is your great takeaway that you would like to tell all of our listeners, from someone who has spent a career and lifetime in this field? What would you like the public to know?
I suppose the most important advice, is that talk with your the people who are taking care of you, the nurses and the physicians, the nurse practitioners, physicians, assistants. If they raise the question of transfusion, ask them, what's the reasoning here? See if it makes sense to you. Ask them what the alternatives are. Ask them, and this is usually part of the informed consent process, so it may be redundant. Ask them what the consequences would be of holding off or not doing it at all, because it's like any other very, very common but serious thing, such as a surgical procedure. I've been a patient myself. My elderly parents were, patients, and so we dealt with these issues. And there often aren't simple answers, but ultimately you're entrusting your health to trained professionals, but you're entitled as a patient, I think, to these discussions about this is not like, can I have the tuna fish or, the bologna sandwich for lunch? You know, it's a pretty serious decision. And as far as healthcare professionals, I think we need to start kind of recalibrating our view of what the efficacy and safety of transfusion is in a wide variety of clinical situations, because the data as they now stand challenge longstanding dogmas that we've held for literally, 3/4 of a century.
And thank you so much, Dr. Blumberg. And thanks to everyone for listening. See you next time. We hope you enjoyed this conversation and found some takeaway or new thought that improves your health. We would love to hear from you. Feel free to reach out to us on our website if you'd like to see what we're up to. Our website is letstalkpbm.com. If you enjoy our conversations, please like and subscribe wherever you listen to podcasts and on our YouTube channel.
Special thanks to our guest and our producer Delaney Coronado and the entire production team for all of their expertise in content creation, technical abilities, and dedication to our message. We appreciate the experts who drive this medical movement forward and our affiliate partnerships who support the work that we are doing. Until next time, stay connected to your blood health.